having to have that dialogue with individuals holding the purse strings, whoever they are, MCOs, states, governments. There's no better storytellers than healthcare individuals. We have such powerful stories we can share from our clients, and listening to the industry, understanding how we can bring value and creating a story around that. I think that's going to be really helpful for the healthcare industry as we transition to this value-based care model.
Welcome to Healthcare Marketing Edge, where we share stories and strategies for healthcare practices. I'm Tim Bouchard, Luminous in Buffalo, New York. Today we're exploring how to market value-based relationships in healthcare's evolving landscape. Our guest is Dr. Enrique Enguidanos.
Close.
I really hope
It's about as good as
I
most
wanted to be
people
the one
would
that got
respond
it.
to.
I hope I didn't mess it up. Yeah.
Enguidanos, yeah.
Okay. All right. CEO of CBCS, which is Community-Based Coordination Solutions. He's a visionary in care coordination and an emergency medicine physician. Enrique, I've known you for a couple of years now, but I'm stoked that you're on the podcast. So why don't you introduce yourself, tell people who you are, what you do, and then we'll go from there.
Thank you. Thanks for having me today. Yeah, as you alluded to, I'm an emergency medicine physician based here in Seattle, Washington. You see a little of my son back in the background, so it's a nice day in Seattle today. I've been in the healthcare field 30 plus years now. Started as a firefighter in LA and had a chance to go to med school. Did that and specialized in emergency medicine. And so I bring about 30 years of clinical experience. I've also had the chance to play several administrative roles in the healthcare, both at the hospital level and a hospital system level. And for the last 10 plus years, as you alluded to, have been running a business as well, community-based coordination solutions. So have that aspect of things. CBCS is what I affectionately call a 24/7 navigation service. So the quick and dirty is that while I was serving as an emergency department medical director at the biggest hospital here in Washington, we had a lot of folks that would come into the ED, the emergency department, 100, 150, 200 times a year, a couple of dozen. And thanks to the wisdom of my dyad nursing director at the time, we started a program based out of our hospital that really met with the individuals outside the walls of the ED, heard their stories, and realized a lot of what brought them to the emergency department wasn't really medical, had to do with social determinant of health issues. And so we started a program trying to address those, and it was so successful. That program at that hospital continues to this day. But as the word of the success expanded, I was asked to bring that model to other hospitals, other regions, other states. And from there, the business of CBCS developed. So we basically have live personnel in each community we serve. We call it Navigators. And about 3 to 5% of the healthcare population, whether it's a state Medicaid agency or a MCO, about 3 to 5% of their personnel, of their enrollees, they have names and maybe a phone number and address that works or doesn't, but they don't know who they are. On average, our enrollees have about 5 care coordinators assigned to them, and no one is really working with them. So our task is to find them and bring them back, hear their story, find out why the miss is happening, and bring them back into the fold, back into the existing services in a way that works both for them as well as for the healthcare system. So that's the short and dirty of what CBCS is all about.
This is where the value-based care kind of comes into play.
Yeah, that's exactly true. So, healthcare, I mentioned Medicaid. Medicaid often helps cover services for those that are disenfranchised, that don't have a way to cover their care. And a vast majority of our enrollees are served by Medicaid. It's not an exclusive Medicaid program, but we're often dealing with individuals that are homeless, struggling with behavioral health or substance use issues that, if not attended to, evolve into crisis events. And if the crisis happened after hours or on weekends, oftentimes the only place available, I say this jokingly, but it's really real, is the emergency department, um, the jail system, or the morgue. And we're probably
Mm,
the better of those three options. And so, I'll say, as Medicaid got developed in what we call a fee-for-service system. So, you provide a service and you get paid a certain fee when it got implemented back in the 60s. And whole industries evolved around that fee-for-service to take advantage, good people trying to do good work, but it's evolved into this mass where currently, way back in the early 60s, healthcare was about 6% of the GDP, and today it's almost 18% of our gross domestic product. So the animal's just gotten out of control, and one of the ways to try to address this is what you mentioned, value-based care. Really, our focus at CBCS and much of healthcare is turning in that direction, is trying to find out how do we bring and how do we demonstrate value for the care we're giving, rather than expect some automatic service, some automatic fee for the service we're providing. And I can
yeah,
provide so many examples of that. I mean, my wife had needed an MRI the other day, right? And it wasn't an urgent, emergent thing, but she went to our insurer and said, "Hey, just tell me how much this MRI is going to cost before I order it." And they wouldn't tell her. They said, "Well, you got to go and get it done, and we'll bill after the fact." And so she finally said, "Nah, I'm going to go." She found an outpatient provider. She found out how much it was going to cost and found someone that would do it for a third of the cost. And
yeah,
she
that's
got
a
her
whole
issue
other
addressed.
topic.
Yeah, but
Where you
that's
can,
our
yeah,
healthcare
there's
system.
there are some. I'm hoping to get someone on the podcast in the future about this, where you can, ask for direct billing quotes versus insured quotes. Completely different topic, but yeah, yeah. It's hard to communicate how that actually works too, and you're trying to get MCOs to buy into this type of program and understand
Yeah.
what it can do for them and the costs it can save and the people that it can help. And in our work with CBCS in the past, we've leveraged storytelling a lot to do that. We've created fictional characters to talk about
Mhm.
where that person's journey might find them and what they could get when they receive help or guidance, I should say. And then even what it does on the back end for the organizations too, in terms of prevention and financial prevention as well.
Yeah, I mean, fortunately or unfortunately, we haven't been at a lack of real stories to be able to share. And, I can think of a simple example where, oftentimes when we're engaged by a customer, by a state Medicaid agency or a Medicaid MCO, they'll have a list of a few thousand individuals in, say, the state of Virginia or New Mexico or Alaska or Ohio, where we're working in, and 5, 10,000 individuals that meet their criteria. And we'll get a name and a phone number and an address, which may or may not be valid, and instructions to go find them and connect them. So we had one individual who, used dialysis, but they were missing their dialysis appointments frequently. And setting up, they claim because of transportation. And when that's not attended to in a regular fashion, it can develop pretty quickly into crisis events. And they were, in fact, using the emergency department very frequently, much more than you'd expect for dialysis related issues. And when we spoke to them, they said, "Look, we'd love to get better care, but I keep on calling this transportation service and they're not showing up at the time they said they're going to show up for my transportation to dialysis." We called the transportation service and said, "Yeah, that they're never at the place that they told us they're going to be to meet us." We showed up on a day that dialysis was occurring, that they were supposed to be picked up, and it was an apartment complex. And the transportation service was coming to the front of the apartment complex. The patient was waiting outside their door, and the two never connected. Both well intended, but
Mm-hmm.
multiple times this transportation service was just showing up where they thought was the right place. And once we made that connection, her ED visits disappeared and the admissions that were related to it. You think about the cost of an ED visit, $3,000, $4,000, depending on the case, and the cost of an admission, $10,000, $15,000. Just that simple act of finding where the transportation service should meet over the course of a year is saving over $100,000 for that individual. Both parties well intended, right? We just hadn't made the connection about where to get picked up. When when you think about value-based care and how to make those connections, it's really all parts. It's not just the ED visit, but it's listening to what services the client's needing. Where do they see the disconnect, and where does the other party see the disconnect? And then just trying to merge those as best possible. And there are umpteen stories in any given community about those disconnects.
I was going to say the scale of that when you really think about taking an isolated case like that and then applying it to what the actual volume of need is becomes pretty mind-blowing when you think about it. And we've talked about that in the past, and you have
Yes.
a cornerstone theme in the CBCS messaging, which is that this type of preventative action for underserved patients, or patients that have these disconnects with the system, it's savings on the cost side for the MCOs too, and it also helps with the Medicaid programs not being inefficient essentially.
Yeah, and it's in some ways so simple, right? It's about listening. And, the healthcare system was created by people like me, for people like me, for doctors and administrators in a convenient fashion. 8 a.m. to 5 p.m. we're going to offer these services, and life just doesn't work in that way. So as we listen to the stories of those we're serving and find out where the disconnects are, it's often really, really simple issues, like, making sure a transportation pickup happens at the right place, a translation service, that the emergency departments in our country have been pretty good about incorporating live translation services for hundreds of languages, right? But that's not true across all of healthcare. So I can't tell you the number of times that CVCS encounters individuals that are going to an emergency department because that's where things can get translated best for them. And we then will just bring a simple solution like a translation service for multiple languages, and that grabs the individual early on and prevents crisis development, prevents them having to go to a expensive ED just to get good translation. So, just that listening is such a pillar, such a cornerstone for what we do, and translates into the value that you had mentioned.
What's interesting about that is that act and that service, if you will, that you're helping make the connection on there isn't even technically about the healthcare itself. It's about facilitating. You talk about the listening side. That's empathy. It's understanding who you're serving, what their scenarios are, where they may find themselves, and your navigators actually contribute to that too, with the backgrounds and the types of people that you bring in to help with that. But it's actually about helping them with these aspects of their life to help get them to the right care, and then that also benefits the organizations on the back end too.
Yeah, you mentioned our staff, and they really deserve all the credit. They are the magic that makes it happen. And we hire for lived experience. It's not a requirement, but when you have wonderful staff like we have, bring in that knowledge of lived experience, the street knowledge, the empathy, the capacity to listen, and can then merge that within the healthcare system. That's really where you start to identify the gaps that you can start filling effectively. And it's the magic of this. Go ahead.
Yeah, I was going to say, if you could indulge me for a second, this actually could apply more generally to just healthcare practices in general too, where if you can think about the patient scenario and what patients are going through, you can, of course, improve your patient experience on location in the treatment and systems and processes you have in the practice. But from a marketing side, we're a marketing podcast. You can also take more empathetic communications out to the patient recruitment process or even the provider recruitment process for a growing practice. And so there's a bit of a connection there into what you're doing from actually reaching into the community to what small practices could do, trying to reach patients and providers too. But I thought there was a nice synergy or whatever you want to call it there between the two.
Yeah, I'm a expensive technician. I got trained as a medical professional, as an ER emergency department doc, to learn a certain set of skills, and I and my cohort of fellow physicians and nurses and staff in the emergency department and in all walks, out in the clinics and within the hospital, do that job really well. But more and more, we're asked to do so much in so little amount of time that you're focusing on the medical side of things. And yeah, people have medical needs, but those aren't the only needs that they have. And so the role of navigators, someone that one understands the background, but two is also good at listening, that can then complement the medical care that we're providing, provides such value, and it's humbling. I mean, I can't every day I'm learning from our staff, their ideas, the things they've picked up on that I didn't because I wasn't really listening to the full story. I was paying attention to the medical side of things. It's that role of navigation is such a huge compliment. And you talked about marketing and business, very inexpensive compared to the cost that I bring to the healthcare system as a physician.
Yeah. Have you found it easy or hard to communicate this type of approach to the MCOs? Just straight up, are they understanding it? Do they buy in? Are they having trouble internally getting buy-in? It's a very complicated thing. It's complex, really.
Yeah, there are MCO being the managed care organizations, right? There are great people. I've found a lot of times we practitioners in medicine feel like we're on the battlefield. Medical providers on one side and the medical industry, MCOs, Medicaid on the other side, and we're battling each other. We're enemies. And it's really not the case. I mean, we're really two parts of a system that are working towards a common goal. And it's understanding the language. I've gained so much by learning the finance side of the healthcare industry and where that's coming from. And when I start to understand that, I get better. And there's stuff I have to teach to the MCO industry. I do think I alluded earlier to the value-based care. I do think as an industry, we're going to gain a lot as we're in the midst of this transition from a fee-for-service model towards a value-based care model. And I have found, to answer your question, the more I can let our MCO partners, our state partners know early on how and where I can bring value, I get in the door quicker. I can get into the dialogue quicker. So it's on me to recognize where they identify value and find ways to bring that to them.
Yeah, I don't want to oversimplify it, but I feel like right now healthcare is very much hammer and nail, and your approach is more like the listening thing is sort of the like head on pillow. Maybe it was just the pillow that was needed. Not to get too literal about the head thing.
Yeah, no, I think that's a good analogy.
What do you think is the biggest lesson that healthcare organizations can take from this? And maybe there's two sides to it. Maybe it's just, I have a lot of small and medium-sized practices that listen to this podcast, but the larger organizations are learning from this type of approach too.
What a great question. What a great question. And this is going to sound so ridiculous to some, but it's listening. I think all of us bring such a great level of expertise in what we do. We're all caring individuals. The healthcare and insurance industry, the MCOs, the providers, all want the right thing to be done. And we're trying to navigate this the system that in the midst of change, we're talking here at the
Yeah,
beginning of
lots.
July in 2025, and Medicaid, we don't even know if it's going to exist here in the next year or what it will look like. And so,
Mm-hmm.
in the midst of all that, I think as we listen to each other, as we listen to our enrollees, our patients, and understand where each of us find value, and it's not always a simple solution, but a lot of times it's surprising how simple what a patient identifies as value really is, and what an MCO identifies in value, and how then I can adjust to that.
Now, is there, I always ask this question, this is the wild card. Is there anything I haven't asked you that's part of this conversation that you've been dying to say?
Oh, you were very welcome of the listening side of things. I would have to say we we all have to do that really well. I think continuing to be innovative, continuing to think about where value lies, what each of if you think of healthcare as a spoken wheel model, where you have the enrollee, the patient in the center, and all the services that the individual interacts with as a spoke or in that wheel, just trying to figure out how we communicate with each other and how we identify value, and avoiding duplication to the extent that's another big part of the healthcare industry. I don't think we communicate. If you think about the air traffic controllers navigating planes coming every 30 seconds in and out of an airport, we don't do that well. People aren't transitioning in and out of hospitals very effectively, in and out of their appointments very effectively. And so to the extent that we can communicate better, slowly work towards a common communication language within the healthcare industry, between hospital systems, between healthcare systems, I think there's a lot of low-hanging fruit that will identify the areas.
Yeah, there's going to be it's a hard shift to do, a mindset shift too. And I think both on the healthcare side, providers and insurance and government are all trying to figure out how do we not do the nail and hammer approach. And I think the general public is trying to figure out how to come around on that too. So I guess that's not a very good. I'm saying everyone's lost. So maybe it's not that, but it will take a lot of people putting out messaging and communication that makes sense to both sides to be able to
Absolutely.
pull this stuff together. And it's not easy to do that. And I think something that CBCS is doing, and I know you're doing it primarily to get buy-in from Navigator recruitment and from bringing this concept to the MCOs, is really leaning into the stories, the relatability of it. And I think if you just take that at high level, the relatable stories and understanding people's situations, it doesn't just apply to CBCS and this type of prevention. It just applies to very good, succinct messaging from people that know more than the people they're serving to try and
Yeah,
bring them comfortably into the system.
I think you're spot on, Tim. And you asked what more would I suggest, and what you just said, I think for my cohort, physicians, the healthcare industry, as we're transitioning to value-based care and having to have that dialogue with uh, individuals holding the purse strings, whoever they are, MCOs, states, governments, um, there's no better storytellers than healthcare individuals. We have such powerful stories we can share from our clients, and listening to the industry, understanding how we identify, how we can bring value, and creating a story around that. I think that's going to be really helpful for the healthcare industry as we transition to this value-based care model.
Yeah, I'm all about the patient centric side of things. You hear it a million times on my podcast and on our website and my LinkedIn and everything. But I
And
couldn't
you
agree
guys do a
more with
great
that.
job. I'm glad we're aligned with you all, because as far as storytelling, you know, shout out to Chris VP of Business Development, and his work with you has been tremendous in the storytelling.
Cool. Well, this has been great. Where can people find out more about you and CBCS?
Yeah, I welcome if anyone wants to visit our website. So www.cbc Charlie Boy Charlie solutions.org. We have some nice work that, thank you, Tim, you and your teams have done around the work we've done around the different case scenarios, the different projects we've had around the country. And we have our outreach numbers there on the website as well. So thank you for.
And there's more to come, but we won't get into that right now.
Amen.
All right, listeners, if you want to take your practices, branding, and patient recruitment to the next level, you can take advantage of our patient pipeline blueprint session offer. You can look it up on our website, luminous.agency/blueprint. It's 60 to 90 minutes, a workshop to uncover how you can attract new patients and convert more inquiries into appointments. If you want to hear more like this, you can watch us on YouTube, subscribe on Spotify or Apple Podcasts. And Enrique, thanks again. This was a great conversation.
Tim, un placer. It's been a pleasure, man. Thank you.